Okay, so we'll go ahead and get started, everybody. Thank you all for being here. If you didn't know already, I'm Zeff Arroyo. I'm anesthesiologist, newly anointed medical director here at the YSC. Here to talk to you today about local anesthetics of the YSC. So, name of the talk is Comfortably Numb. John would like me to see a show of hands of everybody that knows the name of this song, knows it's a song, and knows who sings the song. Show of hands. That's it? That's it? Wow.
You're right.
Okay, yeah. So local anesthesia in the YSC, not the most exciting topic, but we'll try to get you information that's useful. There's a lot of information packed within a short amount of time, but if you could take away just one or two things that'll help you in your nursing practice, that's the goal here today. Of course, you're here to get some contact units today, so we will try our best to get you those units, but yeah, we very much appreciate you being here today. As far as me taking over as medical director, one of the reasons I took over, and one of the things that makes me excited about taking over for Dr. Schneider is the high quality nursing staff we have here at the YSC. I feel like we have the best of the best in this region. And the reason we have the best of the best is because you all are very intelligent, you're very motivated. And the reason we're going to try to keep you there at that level is by offering these education talks on a fairly regular basis. Christie's has an idea to have this done on a monthly basis, and that's a great goal. It's our goal to keep you up on the latest and greatest, and like I said, it's very much an honor for me to take over today. So as far as local anesthetics, we'll get to the slides here in just a second, but a quick overview of what we're going to talk about today. Number one is the local anesthetic policy. Number two is types of local anesthetics that we use at the YSC. Number three is going to be the meat of the subjects is going to be, and the meat of the talk today is going to be local anesthetic systemic toxicity. So it's otherwise known as LAST. So we'll spend a fair amount of time talking about that. And then if time permitting, we'll talk about local anesthetic allergies, methemoglobinemia, and then there was a request to talk about Exparel, so we'll talk about that too. So like I said, a fair amount of information in a short amount of time, and then if there's time at the end, I'm happy to take questions at the end of the talk. So
You may have to manually do this.
Sure.
This thing is not brand new batteries and it's not functioning.
Sure.
Come on. Yep, you can do the arrow keys.
All right.
Long way.
There we go. So again, real quick, three forms of anesthesia if you didn't know: general, local, and of course, anesthesia lectures. This is the quick overview that I spoke about here, and we'll just hop right in. So this right here is not a pre-op assessment, but there is information that's helpful in there. There's got your ASA, you got your airway exam, you got your turn-ons, turn-offs. So not exactly what we're looking for, but there is some useful information in here. So what is the local anesthesia policy? So Heather Mall did a real nice job putting this policy together. You all should have a copy of this. And I'll just direct you to page 2, and I'll just read the policy real quick, and then we'll go into kind of the highlights of the policy. So the policy states it is within the scope of practice for a registered nurse to care for a patient receiving local-only anesthesia during surgical, diagnostic, and therapeutic procedures in the operating room without the presence of an anesthesiologist. At minimum, one perioperative RN circulator with BLS certification should be dedicated to each patient undergoing an operative or other invasive procedure and should be present during the patient's entire intraoperative experience, including local-only anesthesia cases. So that, in brief, is what the policy states. There's a lot of detail that Heather put in there that you should definitely read over later, but we're going to hit on the highlights today. And some of the things that stood out to me in terms of the pre-op assessment, is, first of all, anesthesiologists were very, very picky in terms of, and needy in terms of what we need to go back to surgery. We like our patients MPO, we love our IV access, and we love healthy patients. So all those things we're very picky about, and none of those things you necessarily have in a local only case. So as the perioperative nurse, in the pre-op assessments, it's kind of tricky sometimes dealing with these patients because number one, they're not always going to be MPO. Some of them eat and drink day of surgery, which we allow because they're not going to be sedated. Number two, IV access is not necessarily going to be there for us, so be aware of that. And number three, these are sometimes the most sick patients that we deal with. Oftentimes the reason they're straight local is because they're too sick to undergo a general anesthetic. So it's a lot of pressure on you nurses to have to cope and figure out whether this patient is safe to undergo an anesthetic even though it's straight local. So I do review charts before they come back to surgery to determine whether they're appropriate for the YSC. But it's going to be a pretty rare occasion that I'm going to turn down a local only case at the YSC. But it's really imperative for you to know if you're uncomfortable going back to the operating room for whatever reason, you need to talk to the surgeon, you need to talk to the anesthesiologist in charge that day. So please express your concerns. If you feel like this should not be done at the YSC, it's not a problem. Well, it shouldn't. Well, the surgeon will say it's a problem, but it's not a problem because we could always do this at the hospital at another time. These are very rarely emergent cases. So please express your concerns when it comes to these ASA 3s and 4s. And then what's a little different for you all versus anesthesiologists is that you really have to walk the patient through the steps of the process, what's going to happen in the operating room. As anesthesiologists, our quick pre-op is taking a history, telling them they're going to go off to sleep, you're going to wake up, we'll be all done. For you all, it has to really go step by step in terms of we're going to take you back to the room. You do have to lay flat. Can you lay flat? This is the position you have to be in. How do you ask for more pain meds if you need it? So if you're hurting, how do you communicate that? And then walk them through the post-op process too. So a lot of pressure on you to get these patients ready to go for just a straight local case, which the surgeon thinks it's a Ditzel case. It's a Ditzel case. But for you guys, it's a lot of pressure sometimes. So if you feel like you have concerns, please express those concerns. As far as the intra-op assessment, on page 3 of your policy in the number 5 section, it is important to determine how much local anesthetic that patient can receive. So that's a typo. That's should say maximum dose, not minimum dose. So it is weight dependent. And we'll talk a little bit about how you determine those dosages, but it is going to be up to you and the surgeon to determine how much local anesthetic that patient can receive. And again, using the lowest effective dose to achieve the desired effect is going to be an important thing, mostly for the surgeon, because he's the one administering the local. But for you all, you have to be there to tell the surgeon the patient's feeling that a bit. You need a little more local anesthetic doctor. Those types of things. But like I said, it's more of a surgeon thing, number 2 there. And then quick and dirty conversions that I've always found useful in the operating room to determine maximum toxic doses for patients. You have to first know whether it's 1/4% or 0.5%. And for me, it's very easy for me to calculate the dose based on weight. For 1/4% local anesthetic, whether it's ropivacaine or marcaine, it's a cc per kilo. So, for example, for a 70-kilo patient, the maximum dose is going to be 70 cc's of 1/4%. So just know that there's a little fudge factor there. If there's epinephrine in the injection, you've got a little extra buffer to go up on that maximum dose. But it's always kind of, like I said, for me, it's very easy for me to think of 1 cc per kilo for 1/4%, and for 0.5%, it's going to be half of that. So for a 70-kilo patient, it's going to be 35 cc's will be the maximum dose. So if you're in a pinch, you're trying to figure out maximum doses for a quick local case, that's helpful for me. And this is a chart that kind of spells that out. You can do math if you want, but for me, it's just easiest to do the 1 cc per kilo or half cc per kilo for those patients. But for example, bupivacaine is the most commonly used local anesthetic we use in the operating room. And 2.5 milligrams per kilogram is essentially a cc per kilo. So that's what we're dealing with there. So moving on to types of local anesthetics that we use in the operating room, I think it's very easy for a lot of us anesthesiologists to assume that you know what medicines we use. We assume that you know what the different local anesthetics are and why we choose them. But we'll just go briefly through the types. It's not too much minutia that you need to know here, but there are 2 types of local anesthetic classes. There's the ester and the amides. The ester local anesthetics we don't use a whole lot of. There's procaine, chlorprocaine, and tetracaine. As far as what we stock here, I believe it's just chlorprocaine, which we use for short-acting spinals. The most commonly used ones are going to be the amide local anesthetics, and that's going to be lidocaine, bupivacaine, ropivacaine, and mepivacaine. So you should all be familiar with those drugs. Mepivacaine we're starting to use more of on the West End for Dr. Krellin and Dr. Shear for our short-acting spinals in their joints. But we'll probably see more mepivacaine here downtown also in the near future. So as far as a quick and dirty way to distinguish one from the other in terms of which class is what I always learned in medical school was that the ester local anesthetics are the anesthetics that have 1 eye in them, and the amide local anesthetics have 2 eyes in them. So that's a pretty easy way to kind of figure out which one's which, because they're all in the same class. So if there's a true allergy to one of the types of local anesthetics, then you can certainly use the other class. That should be fine. And we'll talk about local anesthesia allergy here in a little bit. As far as how we choose the type of local anesthetic, again, that's going to be up to the surgeon, up to us in terms of what we use in our spinals. But for those of you that don't know why we choose them, we have the short-acting local anesthetics. That's going to be chlorprocaine, lidocaine, and mepivacaine. And the duration of action of those medicines are going to be anywhere from 30 minutes to 90 minutes. The moderate-acting medicines, bupivacaine and ropivacaine, are going to be the moderate-acting from 4 to 6 hours. And then the longest-acting medicine, as we'll talk about later, will be Expro, which you all are familiar with. So does anybody know here why we would choose bupivacaine over ropivacaine or vice versa? Anybody know why? What if we had the choice between bupivacaine or ropivacaine for a nerve block? Any ideas as to what we would choose?
Ropivacaine because it has less cardiac toxicity.
Yeah, that's right. That's one of the reasons. So Heather said that less cardiac toxicity, which is right. That's bupivacaine has a little more cardiac toxicity. And then the other reason is ropivacaine has less motor block. So in those nerve blocks or spinals where we want to get them moving a little quicker, ropivacaine is a better choice. Otherwise, they're pretty similar. They last similar durations, but those are 2 reasons why we would choose one or the other. Any questions about the types of local anesthetics before we get moving? So the meat of the topic today is LAST, or local anesthetic systemic toxicity. And instead of me trying to explain all this in a short amount of time, I've got a quick YouTube video about 10 to 12 minutes long. It's really clear and concise, a lot of information, but I believe Christy will provide the link to the YouTube video after the talk, so that'll be available to you after the talk if you want to rewatch it because it was so exciting and thrilling. So, so Dave, here, come here.
Local anesthetic systemic toxicity, or LAST, is a potentially fatal complication of local anesthetic use. The presentation can be variable, but a substantial number of these cases result in permanent injury or death, and understanding the ins and outs of this complication is a must for any clinician using local anesthetics. In this video, we'll review the mechanism, the clinical presentation, as well as strategies for prevention and management. LAST is an overdose of local anesthetic and happens either because we've accidentally put a big dose of local in a vessel, or for whatever reason, the local we've administered into the correct body compartment is just too much for that particular patient, and the plasma levels hit a toxic threshold. Is this a rare complication? Maybe. Our best numbers suggest that it happens in 1 to 2 in every 1,000 nerve blocks. However, those are just the ones we know about from prospective registries or databases. There are no doubt several-fold more cases that go unreported, especially if the outcome is favorable. Our understanding of how LAST presents has evolved over the last several decades, and especially in the era of ultrasound and fascial plane blocks. The classic presentation was based on rising levels of plasma local anesthetic and started with the prodromal symptoms, numbness around the mouth and tongue, ringing in the ears, a metallic taste, and some other non-specific neurologic items. Then, as plasma concentration increased, the patient would become agitated, restless, and start to twitch and eventually seize. Only the cases with the highest plasma levels would develop arrhythmias and cardiac pump failure. It's important to understand that while the syndrome can present in that specific order, it certainly doesn't have to. More contemporary data show that just under half of all cases present initially with neurologic signs and symptoms. Makes sense. A third present with both neurologic and cardiovascular manifestations at the same time. So that means that about 1/4 present with only cardiac signs. That's not good. In the old days, we kind of relied on the paradigm of, hopefully I'll catch the LAST early because I'll watch for the prodrome. We know that's just not reliable anymore, and this speaks to the need to remain uber vigilant about preventing LAST. Another thing that's changed is where it happens. While the majority still occur in hospital, about 40% happen in ASCs, outpatient urology clinics, cosmetic surgery clinics, dental offices, and so on. As anesthesiologists, we used to own this complication because we were the ones using large volumes of local anesthetic and running into trouble. In the last 10 years, we've seen an uptick in the proportion of LAST due to surgeons and other proceduralists. At least part of that trend relates to tumescent anesthesia for liposuction. The site of injection seems to matter too, although that picture has changed slightly as well. A commonly taught list of injection sites ranked in order of potential for systemic absorption started with intercostal and epidural and ended with subcutaneous, and it made sense that these might represent a graded risk for LAST. More recent case reports suggest that procedures such as penile blocks in children and local infiltration analgesia for joint replacement are bigger culprits. This probably represents inattention to dosing limits relative to patient size. Neuraxial is still up there, as are upper extremity blocks and paravertebral blocks, but keep in mind that there is no site that is truly safe from LAST. The toxic mechanism is complicated and not fully understood. We do know that part of it relates to blockade of sodium channels in the heart and central nervous system, but there's also inhibition of other membrane ion channels, including potassium, calcium, and others. However, the primary toxic mechanism probably relates to poisoning of the mitochondrial oxidative phosphorylation pathway. To put it more simply, the cells just can't generate ATP for energy. They're metabolically asphyxiated. As you might expect, the organs that are most intolerant of intracellular energy depletion are the heart and brain, which is why the clinical syndrome manifests as cardiac and neurotoxicity. This mitochondrial poisoning theory may also explain why the usual hemodynamic therapies like vasopressors and inotropic drugs are frustratingly ineffective in severe LAST. In the brain, high local anesthetic levels first provoke blockade of inhibitory neurons in the cortex, which leaves the excitatory pathways unrestrained. This explains the twitching, hallucinations, and seizures that characterize neurotoxicity. At a higher threshold plasma level, the excitatory neurons get blocked too, resulting in CNS depression and coma. In the heart, we see sodium channel blockade of conducting fibers, which provokes either bradycardia or reentrant tachyarrhythmias. There's also a direct myocardial depressant effect from calcium channel blockade and interference with the myocardial sodium-calcium channel pump. Add on to that the mitochondrial poisoning, and you can see how the heart muscle begins to fail fast. Now, we have an antidote for this poisoning: fat. Specifically, a 20% emulsion of triglycerides and phospholipids. It's amazing for its sheer effectiveness at reversing the toxic changes after local anesthetic poisoning, and the fact that it's cheap and plentiful makes it all the more attractive. So how does lipid emulsion work? It's actually multimodal, but the first and principal way it works is by scavenging lipid-soluble local anesthetic molecules from the heart and brain tissue and shuttling them to other tissue depots, notably the high-mass, high-flow skeletal muscle and liver. This lowers the concentration of local anesthetic at the ion channels in the heart and brain, and when that concentration drops sufficiently, the tissues can begin to function again. The triglycerides also provide fatty acid substrate for the poisoned mitochondria to use, providing a little inotropic kick. There's also a volume effect from the colloidal lipid emulsion that helps generate cardiac output, so it really does work in a couple different ways. When we think about populations that may be at higher risk for LAST, the extremes of age seem to be in that category. Elderly people have cardiac comorbidities that result in a lower threshold for rhythm disturbances or pump failure. They also have decreased muscle mass, which means they're unable to use that as a neutral reservoir for local anesthetics. Babies under 6 months of age have decreased muscle mass too, as well as immature hepatic bile transformation pathways, so plasma levels of local anesthetic may be elevated, particularly since they also have reduced concentrations of alpha-1 acid glycoprotein, a protein that binds local anesthetics in the plasma. For both the frail elderly and children less than 6 months of age, a dose reduction of local anesthetic of 10 to 20% seems reasonable. Pregnant patients have a reduced concentration of plasma-binding proteins and increased cardiac output, which translates to a more rapid rise to peak plasma levels. Add to that the epidural venous engorgement from the mass effect of the uterus, and it seems reasonable to reduce the epidural dose by 10 to 20%, starting in the first trimester. Patients with reduced ventricular function will be more susceptible to local anesthetic-induced myocardial depression, and they won't clear local as fast. Those that already have arrhythmias are at slightly higher risk for developing a serious arrhythmia with LAST-2. Coronary disease doesn't seem to be a risk in and of itself, but remember that you need to feed fat to the heart in a cardiac arrest situation, and if that muscle is poorly perfused because of sclerotic blockages, it will prolong the resuscitation. We don't want to have to manage LAST, so it pays to prevent it. First off, be conscious of published dose limits. There are obviously downsides to a set of limits that don't take into account the site of injection or other patient factors. However, they're a good framework to work from. It's scary to see that there are plenty of reports of LAST with sub-maximal doses. A good rule is to use the lowest dose possible that gets the analgesia you need. Fractional injection means pausing between each 4 to 5 ml aliquot for 20 to 30 seconds to allow the plasma concentration to begin to fall. This is a good safe practice. It can be somewhat impractical with small volume blocks, and we'll typically do this for the elderly patient with multiple risk factors or high volume blocks. Always aspirate before injecting each dose. It's not perfect, there are some false negatives, but they're rare. Epinephrine is used as a marker for inadvertent intravascular injection. We put it in virtually every local anesthetic syringe and have had some good saves where we were obviously mistaken as to the needle tip position. Epinephrine also truncates the peak plasma level of local anesthetics. And finally, use ultrasound. We now have evidence that ultrasound-guided blocks are associated with a significantly reduced incidence of LAST over a non-ultrasound technique. So use it. 3 special situations deserve a brief mention. Fascial plane blocks carry a somewhat higher risk for LAST for 2 reasons. 1, the target intermuscular fascial plane is sandwiched between 2 reasonably vascular muscle bellies, and so uptake is relatively quick depending on the individual block. We also use large volumes such as 80 mL total for a bilateral set of blocks. In these cases, it's wise to dilute the local anesthetic down to stay well within dosing guidelines. The nerves in these blocks are generally quite small and easily blocked with dilute local anesthetic. Catheters are wonderful, but be aware that most of the data we have to date shows that the total plasma levels of ropivacaine do continue to rise for the duration of the catheter, and so care should be taken when planning the infusion regimen. Again, the least amount of local possible to get the job done is the right dose. Fortunately, the alpha-1 acid glycoprotein also rises following surgery, so while the total plasma level may be high, the actual free fraction is not as high as you might think. Special care should be taken with multiple catheters. Intravenous lidocaine has been the culprit in a number of serious LAST cases. Even in normal doses, over 10% of patients report mild CNS or cardiovascular disturbances. A recent international consensus statement has recommended that infusion rates go no higher than 1.5 milligrams per kilogram per hour and only infuse for 24 hours. A block should not be performed within 4 hours of starting or finishing the infusion. The worst happened and you've got a case of LAST. What are your first steps? First, stop injecting the offending poison. Call for help, and if you have a lipid emulsion kit prepared, call for that specifically. Maintain the airway, and if necessary, ventilate the patient. The seizure produces a profound hypercarbic state, which vasodilates the cerebral arteries, promoting the delivery of the very agent we want to avoid to the brain. You want to aim for eucapnia or slight hypocapnia. Stopping the seizure is important, and benzodiazepines are the first line. 2 milligrams of midazolam is usually sufficient. Propofol should be used sparingly as it will have a negative effect on blood pressure and cardiac output. At this point, you're going to want to give the lipid. I recommend delegating one individual to manage the lipid portion of the resus. Direct him or her to withdraw 1.5 mils per kilo using some big syringes. This is your bolus dose, and you want to get it in quick. Once the bolus is finished, direct him or her to start the infusion at 0.25 mils per kilo per minute. Up to 2 more boluses of the same dose can be given if needed, and the infusion rate doubled if there's refractory hypotension, but the maximum dose is 12 mils per kilo. Now, doing math in the middle of a crisis is no fun, so here's an easy math-free version that will approximate your bolus and infusion, assuming an ideal body weight of 70 kilos. 100 mil bolus and 1,000 mils per hour on the pump. In the heat of the resus, just get things going with those 2 settings, and then once the dust has settled, you can fine-tune your infusion if needed. Lipid emulsion is very well tolerated, and there are sufficiently few side effects that most experts recommend giving it at the first hint of LAST. You may overtreat some patients who are false positives, but given that LAST can progress quickly, you really don't want to take that chance. If you have the clinical suspicion, give the lipid. It's nice to have your lipid and the instructions in one place. Here's an example from lipidrescue.org where the lipid is in a sealed box with instructions pasted to the top. In a cardiac arrest setting, everything else is the same, but you'll want to carry on with standard ACLS. Standard except for the following. Don't use a milligram of epinephrine. All it does is provoke arrhythmias, wildly increase cardiac work, impairs gas exchange, and provokes a rise in lactate. The goal here is to get flow of lipid through the coronaries, so chest compressions are key. Don't use vasopressin, as it has been shown to worsen outcomes. And obviously, you wouldn't use lidocaine to treat arrhythmias in the setting of LAST. And similarly, don't use meds that reduce the inotropy or AV conduction. Once you've had the patient back and stable for 10 minutes, you can stop the lipid infusion. If the patient has experienced cardiovascular compromise, he or she should be monitored for at least 6 hours to ensure the heart and brain are no longer at risk from redistribution. If there were only neurologic manifestations, 2 hours is enough. If the episode was brief and not severe, it may be best to proceed with surgery, especially if the patient has already been blocked and the block is sound. On the other hand, in cases where the patient is not responding to these measures, consider calling in the cavalry and getting cardiopulmonary bypass or ECMO deployed. Here's a flowchart for LAST management from the American Society of Regional Anesthesia and Pain Medicine. And this is a similar guideline from the Association of Anaesthetists of Great Britain and Ireland. Both are very similar. LAST is a terrible complication of local anesthetic use that, with the right preventive strategies and vigilance, can be avoided. Make sure you're prepared in any setting you use local anesthetics.
Where are we at here, Dave? Voice from here.
Yep.
Okay.
I'm on the right.
Okay, so that, again, a lot of information, short amount of time. YouTube video will be available later if you really want to rewatch this. But this is going to be typically the way LAST presents at the YSC. You're having a really nice day, you're in the block room, chatting with the patient, trying to make them comfortable, making small talk. All of a sudden they start seizing. So what do we do in that situation? As anesthesiologist, I have to address the seizure. So I'm going to need any nurse available to grab the insulipid kit. So that's going to be the most crucial point, is getting the supplies going and me stopping the seizure. So does everybody know where the intralipid is located at the YSC?
Crash cart.
There are bags in the crash cart in phase 1
And the block room.
and the block room. So those are the 2 locations available where the intralipid is available. So I believe it's the bottom drawer in the block room, and in the crash cart, bottom drawer crash cart. I believe we have 2 bags of intralipid along with the card that kind of walks you through how much to give. At the West End, for those of you that work at the West End, it's very similar where the intralipid is located. It's in the crash cart and then in the med room in the back part of the pre-op area. In the center core area.
In the hallway.
In the hallway between 1 and 2. So the med room between 1 and 2 would be the other intralipid location. So Cassidy's looking to put together a kit similar to what we see in the video. I don't think we have kits right now. We just have bags and cards. So that might be something worth considering doing as leadership, is having a kit with the bags, the instructions, syringes, all ready to go. As far as highlights from the video that I found most pertinent to what we do here is, first of all, intralipid does save lives. This is a life and death situation, but intralipid is one of those things which is very rare in medicine where you have an antidote to the problem. So intralipid is the antidote to local anesthesia, systemic toxicity, much like dantrolene is the antidote to MH. So again, that's going to be the most important thing, is getting the intralipid on board ASAP.
Bless you.
The second thing is that I found interesting is that prodromal symptoms are not always going to be present. So when I was in training, we're doing epidurals on patients, and we still do this today. When we give our test dose of local anesthesia, we ask any ringing in the ears, funny taste in the mouth, do you feel your heart racing at all? Those are all prodromal symptoms, but it doesn't always present that way. So as the video says, only about, I think, 40% present with a prodrome. Otherwise, they're just going to go straight to seizure or straight to cardiac arrest, none of which is good. So yeah, be aware of that. Know that CPR is different in the last patient. So it's all about chest compressions when it comes to getting the intralipid circulated. So we're still going to give our epi, our other ACLS drugs, but chest compressions is going to be the most effective thing to get this patient in a safe place. It is more common than MH and cardiac arrest. We make a lot of, we call a lot of attention to patients that have MH. We do a lot of things to get the room ready. So a lot of things go into an MH patient, but it's just not very common nowadays because we are so on top of things in terms of family history. Cardiac arrest is, again, very rare depending on the types of patients. Typically here at the YC, we should have less cardiac arrest than across the street at the hospital, but of course arrests can happen anywhere. So, but on the whole, as the video said, it's about 1 in 1,000 blocks, and I'm not sure how many blocks we did last year, but 1 in 1,000 is not very, it's pretty common. So we have to be ready to treat last when it happens, because it does happen when you least expect it. So as far as other things that I found useful information in terms of last, again, it didn't mention it in the video, but last can present anywhere, and that's why it's important that not just OR nurses here, there's pre-op, post-op nurses. We oftentimes think it's going to happen just in the block room when we're doing our block, but that's not necessarily the case. Most of the cases do happen within the first 1 to 5 minutes of injection, with about a 20% of the population would present 60 minutes later as it gets absorbed into the system. So you might see it in the PACU, and it might be hard to parse out what's happening, but know that if they've had a block and they're seizing in the PACU, have that on your radar and have that low threshold to grab the intralipid. So that, and then again, the prodrome, not always going to be present. And then let me see here. I guess that's about it on last. Any questions about last that anybody has here? Again, it's a lot of information. You do have the flow sheets in your packet there, so that if you want to review that chart that the ASRA Association put out, useful information. Oh, one last thing, the math-free intralipid administration. That is also a very important thing in a crisis situation. You don't want to do math. No one wants to do math, but assuming 70 kilo person, it's going to be about 100 cc's of intralipid bolus right away. So that's going to be the most important takeaway for you all, is that I'll be stopping the seizure with a little Versed while you are drawing up 100 cc's of intralipid and giving it right away. Once we give that bolus, we'll go ahead and drip in the rest of the bag a little slower, but the bolus is going to be the key. So math-free administration of the intralipid. No, not really. It's a pretty clean medicine. So as far as side effects, I've given it once, so it's still pretty rare. But yeah, as far as side effects from intralipid, is that what you're asking?
Yeah, like with it being processed through the liver and everything just
Yep.
going so quickly, if there's
Yep.
anything like on the back end of things that
Not really. Like I said, intralipid's a pretty clean drug. with minimal side effects. And that's why we'll talk about it here in a minute. If you have a low threshold of wanting to give intralipid, if you're thinking, do I want to give this or not, go ahead and give it. It's a safe drug, minimal side effects. So yeah, as far as things to look for, not really. So this is the kit we talked about. This is through Lipid Rescue, of course, but if we can have a kit similar to this, it might be useful at the YSC where it's all ready to go in an emergency situation. So yeah,
So
yeah,
these
Ken.
patients, if we had to do this, we're not transferring, or we are transferring after the episodes?
It depends.
I
So
mean, if they seem stable.
they seem stable, we're gonna.
Their family's gonna be really scared
Sure.
about what happened.
Sure. It depends. Per video, if they come out with if you're just treating a milder form of LAS where it's neurological and they come to pretty quickly, then you can even proceed with surgery. And that's one of those things where it's one of those decisions like, is this the right thing to do?
Right, okay.
But it is one of those things where it's going to vary on the severity of the LAS that you're treating, how long it takes for them to bounce back. I would think if they responded to the bolus,
Sure.
woke up, everything was fine, they could go home later that day. But yeah, transferring would be one of those things that we would have to assess
Okay,
on a
okay.
case-by-case basis.
Right.
Other questions? All right, so yeah, real briefly, local anesthesia allergy. Don't see a lot of allergies to local anesthetics. A lot of patients say they're allergic to certain medicines, but it's more of a sensitivity, not a true allergy. So if you're going to have true allergies to local anesthetics, it's mostly in the ester class. So those are going to be the procaine, chlorprocaine, tetracaine, which we rarely use. So the amide local anesthetics, little less incidence of allergy with those medicines. It can be confusing because an allergic situation can mimic LAST. You're not sure what you're dealing with. Patient starts acting strange. They might seize. Is this an allergy or is this anesthesia toxicity? My advice to you is that if you're not sure, give the intralipid because it's safe and you might save that person's life. In anaphylaxis, if it truly is a true drug allergy to the local anesthetic, then you might see bronchospasm and cardiac arrest. So again, bronchospasm not so much in LAST, but bronchospasm's present in anaphylaxis. And the drug of choice, epinephrine and an antihistamine like Benadryl. So again, pretty rare, but it can be confusing, knowing that what you know about LAST now and what it looks like versus what you see in a local anesthetic allergy. It can be confusing, but my advice would be to give the intralipid. If you have that ready to go ahead and give that. If a person's allergic to one class of local anesthetics, you can use the other class of local anesthetics. So if they're allergic to chlorprocaine, procaine, go ahead and lidocaine, bupivacaine, ropivacaine, all those commonly used ones that we use are safe. So be aware of that. So does anybody recognize what might be going on in these pictures here? Any thoughts? Bueller? All right, so what we're looking at here is methemoglobinemia. So what we see in these three pictures are cyanosis. So you see cyanosis in the hand. It might be a little hard to see in these pictures, but cyanosis of the lips and tongue, hands, and then I'll talk about the blood here in just a moment. But this is a quick overview of what methemoglobinemia is. Again, this is addressed in your policy. Heather did a nice write-up on this. But this is also a rare complication of local anesthetics. And what it is basically it's an abnormal structure of hemoglobin in the patient's blood. So instead of hemoglobin on the left, you have methemoglobin, which is an oxidized form of hemoglobin. And in that oxidized form, you have decreased oxygen carrying capacity. So you have less oxygen that gets to the rest of the body. And we're not so much concerned with the congenital type, which is usually a mild form that patients live with. They're born with it. They learn to live with it. But what we're most concerned about is on the right, the acquired methemoglobinemia, which is triggered by topical local anesthetics that we use in the operating room. The most commonly used one is going to be benzocaine or hurricane spray. So I think we as anesthesiologists, and if you nurses have used hurricane spray before, it's pretty easy just to spray as much as you think the patient needs. If they feel like you need a little numbing at the back of the throat for a awake intubation, just spray away. It's fine, but it's not fine. You can run into acquired methemoglobinemia from that, and the way that presents is cyanosis, which is bottom left, and O2 sat in the mid-80s. So mid-80s, that does not respond to supplemental oxygen. So you throw oxygen on the face thinking that the cyanosis will get better, and it just doesn't get better. You have to have a high degree of suspicion as to what's going on. But in addition to that, on the mid right there, you're going to run into what's called chocolate blood, and that was what you're seeing in that bottom left picture there. That far left tube is what chocolate blood looks like, and that's pretty consistent with methemoglobinemia. So again, a pretty rare complication, but hurricane spray seems like a very benign medicine, but it's not. You can run into toxic levels pretty quickly with it. So as far as the treatment for it, it's methylene blue. Little vial of methylene blue that we have here at the YSC, you inject that and you should cure the methemoglobinemia pretty quickly. We didn't have methylene blue for a period of time. It was on back order, but Heather was able to get some more in stock, so that's in the med room, I believe. So the West End is working on getting methylene blue. They don't currently have that, but they'll work on getting that in stock on the West End. If you want to read all about methylene blue, you have that in your packets. Again, very exciting reading. But any questions on methemoglobinemia?
If it's not treated,
Yes.
what happens?
Yeah, you can. This is life and death also if not
Okay.
treated.
That's
So,
what I was wondering.
So yeah, high degree of suspicion because you think patients' hands, lips turn blue, oxygen's going to do the trick. No, not necessarily. So just be aware of that if they're not responding to oxygen, something else might be going on.
Do they require extra monitoring or like lab checks or anything like that?
Yeah, I believe so. I think lab checks initially are going to be warranted. This is going to be something where they might have to be transferred for lab checks, but it is so rare that hopefully we don't have to run across this, because with the amount of video laryngoscopy that we're doing with glide scopes and McGraths, we don't do awake fiber optics all that often anymore. So the wake fiber optics are where you really run into the hurricane spray. I'm not sure if do you use hurricane spray at all? So
I was going to ask, is that what they use in endo?
yeah,
That's what I thought.
Yeah.
Okay.
So
So it's
you
more,
have it in nurse control.
more common in endo, I bet.
So moving on, we have just a few minutes left. We're gonna talk real briefly on Exparel. So again, Exparel is something you all are familiar with to a certain extent, I believe, because we use it on a daily basis here. And one of the reasons it's such a popular drug is because of the opioid crisis that is a real thing nowadays. If we can decrease patients' opioid use post-surgery, then we're doing a good thing. And Exparel's done a nice job of extending pain relief longer than our normal local anesthetics. So I just want to take a few minutes to talk about Exparel itself and things you need to look out for. So as far as what it is liposomal bupivacaine, which is a slow-release, extended-release bupivacaine. The duration of action is anywhere from 24 hours to 72 hours, but know that it stays in the system up to 96 hours. So even though the pain relief is starting to wear off at day 2 or 3, Exparel is still going to be in the system for another 24, 48 hours. We are going to be working on wristbanding our patients that get Exparel at the YSC. We currently do that at the hospital. Any ideas why we would wristband a patient? Any thoughts?
So everybody knows they've had it.
So everyone knows that they have it, and they should not get any more bupivacaine within that time period. So we're going to wristband those patients. So say that they show up in clinic 2 days later, they're having pain, and the doctor says, "Oh, I'll just shoot in some Marcaine." No. Not with that wristband. That would not be safe. Because what we run into in these circumstances with additional bupivacaine, is that you're going to run into a blast or toxic situation because if you mix Expro with certain medicines, that can trigger a toxic response because those liposomes all of a sudden release all at once instead of slowly release over 24, 48 hours. And you don't want that. We don't want that at all because like I said, now you know about LAST, that's how it's going to present, is a systemic toxicity. The meds that you can mix with Exparel, which the OR nurses are very familiar with, it's going to be bupivacaine and normal saline, and that's it. All other medicines, lidocaine, sterile water, those are all no-nos and should not be done because, again, those can trigger a big toxic response. So as far as January 1, we have started doing interscaling blocks with Exparel. As the anesthesia department, we have our concerns, and we're going to talk about that as a group. Anybody know why we might have concerns about Exparel interscaling blocks? Thoughts?
I've only heard.
Yeah,
I
Court?
just heard Tad talking about it yesterday that they seem to be lasting for a really long time.
Yeah, that's true. I guess one of the patients that we have done recently was still numb 3 days later, wasn't moving that arm 3 days later, and he was starting to get concerned, and we would be concerned too. But if that's what we're running into, that may not be ideal for these patients. So that we're still in that feeling out phase as to whether we want to be doing these blocks. There's another reason why we are a little hesitant on Exparel in these blocks. Any other thoughts? Breathing. So oftentimes, with an interscaling block, you can paralyze the diaphragm on one side. And in patients that have a paralyzed diaphragm for 2 to 3 days, that's not going to be very popular. And that could lead to more transfers, which we're trying to avoid. I did contact the Exparel rep yesterday. He's getting me more information on this. But it is definitely something that we're doing currently, but we're going to have to follow up on these patients pretty closely. I mean, Tammy's done, or you all have done 24-hour checkups on these blocks, but I think we're going to try to do these more 48-hour, 72-hour checkups to see what the patient experience is. So more to come on that, but we are, as of January 1, doing interscaling blocks with Exparel.
While we're talking about
Yes.
the phrenic nerve, have you seen any studies of like maybe these patients developing more pneumonia than the
Yes.
average? Okay, so
Yeah.
from a post-op perspective,
Mhm.
probably sending them with an IS and
Mhm.
encouraging them.
Yeah, I think that would be a great idea. Yep. Especially those with pre-existing lung disease.
Sure.
The ones that are nice and healthy, maybe not so much. The ones that are smokers, have a little bit of lung disease, IS would be a really good idea.
I was just gonna add, we will have Kevin here doing presentations, just mini in-services next week, so he'll be out at the West Campus on Wednesday, and then Thursday and Friday, he'll be in our lounge from like 1 to 3 on both days, and I'll get that posted. But it's just kind of come and talk to him, learn about the wristbands, learn more about Exparel. Very informal, but really a great opportunity to ask him some questions as well.
So how long are we gonna ask them to keep their wristband on after they discharge?
I think the 48 hours?
The 96 hours.
We need to decide on that before next week.
If it stays in the system for 96.
Yeah.
Doesn't the wristband say it? I feel like it says
does.
leave on for
Oh, it does?
96 hours.
It says 96 hours on
It does?
Okay.
Yeah.
Okay.
Okay, very good. Very
And then
good.
what we'll decide today in our clinical leadership team is like where the wristbands will be kept, who's responsible for putting them on the patient, and then we also have some education flyers that can go on those times.
All right, thanks, Christy. And then last thing on this slide, there's more competition on the way. Exparel is kind of the shiny new toy for all the surgeons, but there's going to be maybe better medicines on the way. Dr. Groover has trialed Zen Relief on the West End. It is a combination of bupivacaine and meloxicam on his total joints. Maybe with similar results, we're not quite sure. He's used it just on a few patients. But just know that right now Exparel is the one, but there will be more competition on the way with, I'm sure, more risks associated with them. So just be aware of that because the opioid crisis is real. And it is our job to do our best to limit narcotic use where possible. So So we're doing a good thing, but we want to do it in a safe way. So any questions on Exparel before we move on? Yeah.
Is Expo, I just heard one of them talk about, one of your anesthesiologists talk about that there's not enough information that shows that Exparel is, the other local agents that
Yeah.
we've used in the past is just as effective as Exparel, and it's cheaper than other agents are.
Yeah, again, I asked that to the Exparel rep. He's going to get me data on that. Of course, as an Exparel rep, he will tell me all of the great things. But again, we need to see the studies and see what's safest for our patients. If we're doing I will say the one block that Exparel is FDA approved for is interscalene blocks, which is kind of crazy to me. We've been doing Exparel lower extremity blocks for a while now, which is not FDA approved. But my thought on that is that they may be thinking this is hospital setting. It is safe, and it is safe, but maybe it is not appropriate for YSC. So that's what we need to kind of parse out. We want to get them good pain relief, but do we want them moving quicker than 3 days? Yes, we want that too. So we need to kind of, that's more to come on Exparel. And just wrapping up, yes, I don't always blame anesthesia. Who am I kidding? Yes, I do. Yes, we're very much used to this. This is the life we chose. But in this particular case with local anesthesia problems, oftentimes, as the video said, 50% of the time it's due to the anesthesiologist. So definitely we are to blame. And it is our responsibility to do certain things. So as anesthesiologists, it is our responsibility to make sure that we don't give intravascular injections. So even though you are assisting us with blocks, aspirating, injecting, it is ultimately our responsibility to make sure that what we're giving is safe to the patient and we're doing it in a safe manner. So no intravascular injections. It's our job to calculate maximum doses. So hopefully you have a better idea of how to do that in the OR. And then it's our responsibility to know how to run a last code. So hopefully you have a better idea how to do that. Otherwise, blame away. We're used to it, but we are definitely to blame in this particular instance. So just to wrap up.